This is your fortnightly instalment where I interview a trailblazing physiotherapist that has shaped the profession we are today. In celebrating their journey, knowledge and insights, you gain the opportunity to plan and guide your own professional journey. My name is Doug Carey and welcome to Physio+10. Welcome to past and new listeners to Physio+10. My name is Doug Carey and our special guest today is Dr Jon Ford. Welcome, John.
Thanks, Doug. How you going?
The background has certainly got to raise some eyes, and you sort of got the suntan and Matt, so it looks pretty good. Well, you normally start these podcasts with a bit of background, like where you grew up and your early schooling. So can you give us an idea what happened to you?
Yeah, sure. Grew up in, well, sort of moved around a little bit in my sort of from 0 to 5, then settled in East Ivanhoe. Went to local public primary school, and then my grandfather funded going to Ivanhoe Grammar, which was a private boys' school, which didn't really enjoy that much, to be honest. Doesn't cater for people who are sort of a bit, I don't know, got their own ideas about things. But yeah, so I grew up in East Ivanhoe with my mum and two siblings, younger brother and sister. Yeah, I was the oldest.
Right. So was you where did the idea for you come to move into a health sphere? Was that from your mum, or you had some relatives that were in that area?
Well, my mum, so not really. My mum did end up going into yoga, but that was sort of some time after I was already a physio. No, look, it was actually from a mate of mine, Rod, whose mother is actually Joan McMeekin, which I'm not sure whether your listeners were familiar with Joan, but she at the time was the head of or second from Pat Kosh. Most of your listeners would know Pat from Lincoln Institute, which is where the physio course in Melbourne was at the time. And yeah, Joan was my best mate's mum, and I was actually paddling kayaks in the national championships, and a week or 2 weeks out, I sort of got this sort of vague, ill-defined triceps pain, which sort of stopped me from paddling, which was pretty distressing. And Joan provided some treatment for that and got me up and running for the national titles, which was good. And yeah, so I developed a bit of an interest in physio there, but it was really only a bit of a passing interest. I didn't really know what I wanted to do. I put down medicine as sort of just because that's what everyone put down. And I missed it out by 1 mark fortuitously. And then eventually, so I went and did science at Melbourne Uni, and then decided in first year that I'll have a crack at physio. So I transferred over at the end of second year science to Lincoln Institute with Joan.
Can you recall what the trigger was for that? Like, you considered it, dismissed it, and then you came back to it. Was there something else that?
I think I had a general sort of notion of, family is very important to me, and an extension to that probably is just I hadn't really thought about what my values were back then in any real detail. I was a bit of a mixed up young man, but yeah, certainly helping people was something that I felt was important, and medicine sort of seemed to pass me by, and I just had that connection with Joan. I did go and do a few little work experience-y sort of type things at the hospitals and in a private practice. So I thought, look, to be honest, I just thought, oh yeah, I like helping people. This looks all right. Notional sort of sports medicine sort of type thing in the background, like a lot of people. But yeah, not a really strongly considered, sort of by chance as much as anything else, I think. And I think obviously helping people. I wanted to help people.
Yeah. No, I think it's interesting when we sort of throw this question to people, the fickleness of what it was that made them decide to do it or to not do something else. And then the ramifications that has going down the pathway of their career. So, yeah. Now, your initials are JJ. Was that ever a nickname, or was that?
Oh yeah, look, I've had a few nicknames over the years. In primary school, I used to be called Figs. I don't know why that's the case. In high school, with my kayaking thing, I sort of did get a bit of a big head, so that big ego sort of thing with what I did with flat water kayak racing, and so I got this nickname Head. And yeah, then in uni and down
Not
at Geelong,
triceps.
not triceps, no. Yeah, JJ would crop up from time to time. It's got a bit of a ring to it. Hasn't
Yeah.
stuck though.
Yeah, okay. So you did physio after your first year of science transfer. Was there a particular reason staying in Melbourne, or you were still, this was a family reason, stay close to family?
Oh, look, I'm not actually a very lateral person, to be honest. I particularly when younger, I didn't really understand what was possible. I think you obviously know internet and all that sort of Google searching and whatever. Not a very well connected person, just generally with networks. So I just sort of did what was sort of sitting in front of me. And obviously I had the connection with Joan as well. So yeah, just thought I'd go to Lincoln. It's a nice
Yeah,
little small, bit like Curtin perhaps used to be, sort of got a bit of that tech sort of feel, 100 people in the course, nice little community.
yeah,
Much
it's
better than
pretty.
Melbourne science, I can tell you, with the massive lecture halls and 400 people and just being completely anonymous.
Yeah, no community whatsoever.
No.
You graduated in '98 from Lincoln. How did you find the university experience overall? You sort of mentioned you're a bit mixed up. Did you straighten up as you went through physio, or get more crooked?
Uh, look, I was pretty socially not that great. As I sort of intimated, I got a lot of my validation through sport, and then I stopped my sport, and then I went into Melbourne Uni, and I was just this anonymous sort of person. So that was a pretty tough year, and it sort of started. I started sort of flourishing a little bit more socially at uni, particularly towards the second half or third and fourth year. I actually met my wife in third year, Michelle. So she was a speech pathologist. So I started sort of developing social connections then, but yeah, I wasn't a socially very adept sort of person. So I was a bit of a library, sitter at lunchtime, just go hang out in the library, and sort of pretend to study. But look, I thought the Lincoln course, as I said, it was really good teachers, really good lectures, and it was a really nice little community vibe with the pub, the Melbourne pub serving Carlton Draft across the road, that sort of thing. That
Key
helped.
points. That's pretty cool. You met your wife in third year, so obviously you were getting out and across. Was it like Curtin? You had speech, OT, PT, all in the same sort of location?
Yeah, yeah, and we'd have shared sort of social things. I was in a band, and so I'd play in the band in at social functions and stuff. So yeah, managed to get out a little bit, even though I was a little bit anxious about it.
Nice. So you were playing guitar back then as well.
Yeah, yeah, had a sort of a covers band, crowd pleaser sort of band. Yeah,
How
bit of
can you
fun.
say you weren't social? There you are, standing in the spotlight, yelling out through a microphone, dripping with beer and sweat.
Yeah, well, I think a lot of musicians, I mean, you hear the story all the time. Musicians are sort of often a bit sort of, I'm not sure whether I'm introverted, but socially awkward, and they sort of immerse themselves in their instrument and just have this obsessive phase where they just play. And yeah, I certainly did that. From about 18 to 20, just played my guitar all the time. That's when I learned
Wow.
how to play guitar.
No, you're in the music room now. You're going to give us a short little rendition of something you feel close to.
I can, yeah, Stairway to Heaven.
Yeah, all right. Well, we'll
No,
keep
maybe
going
next
with
time,
this, and
Dave.
then we might have as an outro music, something a bit different.
Sounds good.
When you finish physio, it's a big
Mm,
transition. That sort of, I'm a student now. I'm a qualified, respectable physiotherapist. What do you
mm.
sort of remember about that bit of freedom and that paycheck when you first graduated?
Oh yeah, I loved. So I went and worked at a rehab hospital, Bethesda, that is now part of Epworth, and that's where the ABI patients used to go. The road trauma patients used to go, ortho and also ABI. And then went down to Geelong Hospital for a couple of years and did the rotations down there. Yeah, I loved just having money. It really was one of those very poor students doing the home brew beer and all that sort of stuff. Um, and yeah, just being able to go on nice holidays, buy a sort of a half reasonable car. Um, but yeah, I think and going down to Geelong Hospital, that was fantastic. Like rural regional hospitals, it's obviously reasonably close to Melbourne, but down near the surf coast, go surfing and just the community down at Geelong was something I tried to replicate. We end up moving down to Red Hill in the Mornington Peninsula, which is the other side of Melbourne. So all of that was really good. But yeah, look, I think the 4 weeks holiday started to get to me after a while, pretty
Only
limiting.
4 weeks holiday.
The only 4 weeks holiday, that's right. So that sort of was one of the reasons, pushed me. I think just inherently I was probably a bit more independently minded, and so the structure and the hierarchy of the hospital system sort of wasn't really a good fit for me across a number of levels, I think. So moved into private practice.
So those first few years, would you say you had a specific goal in mind as to what you were trying to achieve in those first years post graduation, or was it a bit of a suck and see and just move from thing to thing?
Look, I'm probably, and this is the advice I give the students when they come through as well, the undergrad or whatever the postgrad students coming through. I still do believe actually that a hub public or a hospital it is the best way just to hone your skills. I wasn't, again, with my social sort of things, my communication skills weren't very well developed. I was very sort of isolated growing up in terms of understanding the broader world, and, had doctors and allied health all fitted together, different patient demographics, just everything really. I really didn't have a good understanding of all of that sort of stuff. So it enabled me to get a better understanding of physio and the context of physio and all of those basic, what in the undergrad program we talk about those soft skills, which weren't really part of the program back then like they are now, but I think they really did teach me those soft skills and gave me a lot of confidence just dealing with patients, which, I mean, and we see this all the time. I'm sure you come across it. Like you come out as a new grad, you go into private practice, and you've got this sort of person paying money to see you, and your communication skills are pretty limited, and your confidence is pretty low. It's a pretty threatening situation. So I would have crashed if I'd gone straight out into private practice, I think.
Hmm.
But
Yeah, so
no sort of broad sort of. Apart from that, just develop my skills as a physio, my generalist skills as a physio, I think.
Yeah, and then once you did, you sort of recognise that you're developing those things, the limitations started to become bigger than the positives, and so you decided 4 weeks wasn't enough, and I'll go private practice. I'm interested to sort of see if you got more than 4 weeks holiday when you went to private practice. So,
Well, look, I did. So look, I did my last year of the undergrad program. I did an elective placement with Paran Sports Medicine Centre, which later became Life Care Paran. So that was along with Olympic Park, the premier sports med clinic in Melbourne, and had some amazing supervisors there. Michael Kenahan, Bernie Simai, Lynn Watson was there, Craig Phillips was there from Dance Medicine. So a lot of very established AFL sort of physios and up and coming physio. So that 4 weeks, I just learned so much from a musculoskeletal perspective, and I guess it was always in the back of my mind to sort of try and get back to there if I could. I to be honest, I didn't think that I would have a chance to do that, but I hit Bernie up for a job at some stage. I can't remember, and surprisingly, he gave me one. That's right. I started 2 sessions a week after hours, so I was still working in the hospital, but I did 2 sessions a week after hours, just like from something like 5 till 8 or something. And so I got my foot in the door with that.
yeah.
And then migrated to showed them that I had what it took in private practice, and then got a full-time job there.
Yeah,
So,
I think.
look, sorry, go on.
And that's what I was just saying. I was just thinking that for younger physios listening to this and considering career path changes, that the concept of getting a foot in door, be it sitting on the bench, offering some free time at a sports club, or as you say, doing a couple of after-hour sessions, not the most popular, Saturday morning maybe, just because the potential employer is always going to choose the person they can see as dedicated, willing to work, got the right smarts, got the right attitude, over anyone that comes in with a CV that looks glowing, because they know that person, they know what their ability and capacity is. Good tip.
100%. Yep, 100%.
I'm not sure you started, so we're transitioning into private practice, leaving the hospital system behind, but sometime you actually started lecturing at University of Melbourne. When was that? Is that around about now, or did you work a few years in private practice first?
Oh, look, it's a long time ago now, Doug. But no, look, it was after a year or so of working at Cran. In last year of the undergrad program, Rob Laird who's now specialist musc physio, supervised me for an independent project, which I did a systematic review on manual therapy for low back pain. And that really kindled a passion for research. I was completely disinterested in research, like zero. I actually had an aversion to it, but we had to do it, so I did it.
-10.
And I came out of it afterwards just really super passionate about research. So I sort of dabbled a bit through the Geelong Hospital and Bethesda roles. But yeah, well, again, Joan so by this stage the Melbourne course had been set up, so the split. So Latrobe, Lincoln went to Latrobe and Melbourne. So Joan was the head of the school at Melbourne. So there was that connection. But I think probably teaching. I think it relates to this helping people notion, like this idea of helping people, helping students to become the best version of themselves, which helps them to help more people. It sort of, I think, has come through that, and then research as well as a way of obviously helping find the best treatment, which then goes on to help more people, patients and practitioners. So yeah, so I just reached out to Joan and asked for got a tutoring role a couple of days a week, and because I had the flexibility with Paran, that enabled me to modify my hours, and they were really happy with that. So it was a great combination, doing the tutoring, the university stuff plus the private practice stuff.
Yeah, I like that you found your passions kind of early on. Like it all stems off that back of wanting to help people, but realizing that if you follow that passion, it's enjoyable. You like it. You're willing to do more.
Yep.
And it's great that you can find those things and pursue them at such an early stage too.
Well, yeah, I mean, it was all just sort of chance, really. But and it's become a bit of a cliche, this follow your passion thing, which I keep reading articles nowadays in the lifestyle sections of the paper saying, "Oh no, that's not true, and that's overly idealistic and whatever." But I think opportunities present themselves for everybody in life, and I guess I have always been a bit of a glass half full sort of person. So something comes up and it's an opportunity, and you go for it, and then somehow or other you seem to find a passion, or that's what's happened to me at least.
Yeah, no, I agree. If we can think about the biopsychosocial model, and when we talk about people that are anxious and they're so focused on a single track that they just don't see the bigger picture. That's the whole thing about the sympathetic system, is it focuses to survive. And if you're in that mindset, then you won't see the other opportunities or the other solutions, because all you can see is that narrow track of getting out of that situation that you're in. So yeah, it's a good process where we can consider life skills in context of how we help patients as well, because if we can give them that understanding, every cloud has got a silver lining. I believe that's true as well. You might not see it, you might not like it, and you might not enjoy the chaos, but when you come through, you often step back and go, geez, that was so good that happened to me. I didn't enjoy it at the time, but it's good now.
Yeah, 100%. No, it's a good analogy.
I like also you sort of, and I like to find out why, but in the early 90s, you sort of started looking at this thing about multidisciplinary care. Now, for physios listening to this now, that's going to seem pretty standard, but back in the early 90s, I was doing postgrad 92 for a year, and the biopsychosocial concept or model was not mentioned once in that full year of study. So how was it that you came across this so early, given that it wasn't really in general physio language?
Yeah, look, it's interesting. I did dabble with the idea of doing psychology in first year unis. I've always had an interest in, possibly due to my own sort of internal issues, an interest in the psychological side of things and the social side of things. So there's probably just that general sort of interest. But when I started at uni, I got access to the library and just absolutely frothed it. Like I decided at that stage that I wanted to develop a special interest in back pain. I was given an opportunity to work with surgeons and AFL teams in ankles, but I was sort of developing this back pain interest with my reading, and I decided, no, back pain is going to be my special interest. So I just basically photocopied every article that I could from the library and read it and, highlighted and numbered it and had a filing system. There's no EndNote back then. It was all just filing cabinets. And key papers. The Gordon Waddell paper, the 1987 Spine Volvo award-winning paper, which really took. He's dead now, but it was
I'm losing you a bit there, John. I'm not sure what's happening.
studies, RCTs, and treatment protocols from sort of Northern Europe, Scandinavia. So they were, really a key part. Probably those two papers, that Lindstrom paper and the Waddell paper, started me thinking that something, because we were all doing manual therapy and a bit of sort of specific exercise and, some sports rehab oriented exercise, but it was pretty, electrotherapy was still pretty prevalent back in those days. So yeah, I just started experimenting around. I managed to secure this sort of preferred provider relationship with a local hospital. And so, sorry, something weird's going on with my, with a local hospital. So I was seeing all these workers' comp patients as well. And obviously, in a workers' comp system, I don't want to say anything defamatory about the hospital, but, there's a fair bit of adversarial sort of stuff going on, mostly nurses. So I was sort of in that context clinically, it was pretty obvious as well. So all of those influences combined for about a 2-year period, just me sitting up in this room upstairs at Paran, just experimenting around with different functional restoration models and assessment protocols based on that biopsychosocial approach. And from that, really, the STOPS, which I suppose we'll go and talk about later, the STOPS approach to treating low back pain, that's basically where it was developed in those 2 years, combining my clinical experience with the nurses and all of the research. I sort of read about 2,000 papers over that 2-year period and tried to pull all that together.
Yeah. But interesting, this is under your own bat, isn't it? Like, it's not structured as part of like you go on and do your master's and your PhD, but at this point in time, it's really just a self-interest and a demographic of clients that you're seeing. And I guess, when you work in a good clinic, there's a lot of support and encouragement and, explore, don't just do the recipe sort of thing. You're actually at a very inquisitive stage of your career, aren't you?
Mm. Yeah, and look, I guess that just comes down to the passion side of things. It was pretty out there. I remember, and I won't mention the physio, but she said, you got a chronic low back patient, just send him up to Johnny and he'll stick him on a treadmill. Which is what I did. Like, treadmill was a key part of my rehab protocol, but it was, there was a lot of reasons why a treadmill was a really useful rehabilitation tool, because it's measurable. You can bring it right down to sort of 0.8 kilometers per hour. You can have hand support. You can gradually withdraw that. There's so much value of just treadmill as an exercise within a biopsychosocial context. There's a lot of physical benefits as well. So yeah, I was a bit isolated. I'd have to say it was an isolating period, but I think when I started to get a lot of support was when it became a commercial thing. So I became really busy. People just started sending me all these back pain patients because I was pretty focused on doing really good reports as well. I'd do these sort of 2 or 3 page comprehensive reports that was sort of like a gold standard at the time. And people said, geez, he seems to know what he's doing. So I just started getting all these patients. So then the commercial dimension came in, and Michael Kenahan from Paran Sports Med in particular really helped me sort of turn that clinical model into a commercial model where we expanded it.
So just going back, you said, there was one physio threw a disparaging mark in your direction. Did you find there was any support, or did you really feel like this was just a pathway you needed to forge yourself?
No clinical support that I can remember. Craig Phillips was actually developing dance medicine and Pilates like in the next room. He was pretty well developed by that. He had, I don't know, 8 reformers or something, a lot of trap tables. So he was already well on his way. But Craig's, for those who know him, was a pretty lateral, sort of progressive sort of guy himself. So that was sort of a bit of a model, and we'd sort of talk and support each other to a degree. But look, not really. I sort of had to go it alone from a clinical perspective. I'm trying to think of other clinical mentors along the way. To be honest, I probably haven't had any real clinical mentors until my formal studies.
Yeah.
that's when
I'm
I
just
started
surprised, I
connecting
guess you
with them.
said, like, at least you got Craig next door and both of them are functional rehab of a chronic condition. And I had just wondered if maybe there was a bit of an overflow, different approach, but still the same underlying concept, not passive, not electro. Let's get this person up and moving. And yeah, just wonder if there'd be a cross between the two.
Yeah, look, Craig and I, Craig's done amazing things for Pilates and exercise therapy for back pain in particular, but we're quite different sort of people. So yeah, we would talk, but it
Mm.
wasn't really a sort of a click there because we sort of did things quite differently.
And were you starting to bring in the psychology? The bio is pretty obvious, but the psychosocial, how were you getting information and utilising that in the early 90s with this group of patients?
Yeah, so it was really multimodal rather than multidisciplinary. So it was a physio-based approach, and uh, I'm trying to Williams. I've forgotten her first name. There was a cognitive behavioural. Um, I've forgotten her name, but there's basically a narrative review around cognitive behavioural treatment for back pain, and for other resources around cognitive behavioural approach. I started integrating those principles, the Vlayan concepts of the fear avoidance model. Over time, Stephen Linton published the Rebro questionnaire, so the risk stratification stuff. So just over time, I started layering more and more of that assessment, and just through my reading, applying cognitive restructuring and behavioural modification principles into what we did. So it was just basically me sort of working that out through the literature. There was no courses available
Yeah.
back then, and in fact, it was quite controversial. Physios even saying cognitive behavioural in their letter because we weren't psychologists, and so back then it was this. I did have psychologists come and say to me, "You can't say that. You can't do a cognitive behavioural. You can't do cognitive behavioural therapy," which I was very. I would always say a cognitive behavioural approach to a graded activity and exercise program, as opposed to cognitive behavioural therapy.
Yeah, it's an niche. I mean, I think I'm out in the limb on this one too because it's the same with nutrition. Like, surely we can advise a patient that drinking beer is not a good idea if they're overweight. We don't need to be a dietitian to provide
Yep.
that life skill advice. And I find that silo approach somewhat limiting. And I guess I feel it a bit more being in a small country town, on the south coast of Australia. Like, you don't have these resources. But even then, I still don't see the reason why, if you have understanding, why you can't convey that as a multimodal approach to the person's activities.
Look, I agree. Although I did do a perspective piece that published in Motion around, a psychosocial or psychosocially informed physio, and there's a fair bit of data around now showing that physios don't have confidence or the skills to even assess or don't even use screening tools like the Arebro. Like, it's not actually used that often in private practice. So let alone doing a more thorough psychosocially informed assessment and let alone then going and doing some psychosocially informed individualized treatment. So rather than just this sort of one size fits all sort of, quasi fear avoidance beliefs based treatment or pain education based treatment. Um, so yeah, I fully agree with you. Like, I think that, and this is the conundrum in my sort of professional life. Physio's just got so much potential, but then what's actually happening out there and the training, education opportunities and programs, and even what's happening in a research context, doesn't always is not working optimally to try and fulfill that potential of physios as a profession. So I fully agree with you, but I think people have got to also know their limitations and
Yeah.
not dabble in there unless they've got adequate confidence and training and support.
Yeah. Now we've come out of our post grad. Oh no, you did your masters, so that was in 2000. Big year, sport year. Did that interrupt being the Olympics? Did you sort of have trouble getting about and doing things because there's such a focus on the Australian psyche on the Olympics?
Oh, look, not really, to be honest. I love the Kathy Freeman moment. That was,
Mm.
I actually, gym, we've just done a reno and put in a gym, and I was thinking of inspirational photos to put up in the gym, and, Kathy Freeman, that was just an incredible moment in Australian history. But I'm tearing up still thinking about it.
Yeah.
But no, look, I'd moved on from my sports sort of thing, back when I was doing more footy and at Paran.
Yeah.
So no, I just blazed away
Yeah.
and got through the program.
Particular mentors or people came out of that program, and I always found the postgrad masters year pretty inspiring as far as, you got this intense year, a lot of people focus on the same goal. Did you have some
Mm.
people in there that influenced you strongly going forward?
Yeah, definitely. Well, Guy Zito was running the program, and the program was a sort of fairly Maitland oriented from a clinical reasoning perspective program. And I didn't go into the program. It was actually a bit of a box ticking exercise so that I could get the marks to get a scholarship for my PhD. That was the intention. Um, but I got an enormous amount out of the clinical reasoning side of it, as taught to me by Guy. And interestingly, before I did the program, I'd actually pushed right over to the psychosocial. So sort of what's happening at the moment, this sort of pendulum swing. I was doing that back in 2000, before then, because of all my readings about from Waddell and the people I was mentioning before. So I pretty much discounted the biological, but the Musk program sort of brought me into a much more balanced position. And I think I was a bit formulaic beforehand, a little bit recipe based with my program that I'd worked up. But yeah, the clinical reasoning that I developed in that program was really where that formulaic approach became an individualized approach. So you guys very, very influential, and also obviously the clinical supervisors. Ross Simonson at St Vincent's was one that I remember as well.
Yeah. And as you said, hot on the tails of your masters, which is initially the reason for doing it, you went into your PhD. So that's unusual because usually it takes a while to kick around an idea to come up with a thesis title or direction. You obviously pretty much had that pathway laid out in your mind as to what you were going to be doing.
Well, I had Paul Liu, who was, I don't even know Paul, but he's again a Maitland sort of type physio, Essendon Footy Club physio for many, many years. And he rang me up when he found out that I was doing the Musk Masters. He said, "What are you doing your Musk Masters for? You should be doing your PhD." And so he sort of saved the idea that I had to do a PhD. And I think as I went through this notion of individualizing treatment based on clinical features sort of really sowed its seed. And so, yeah, the classification subgrouping thing, through that, it was actually a 3-year program. It was a bit of a hybrid sort of program. So yeah, I had a topic, the classification of low back pain sorted. How I was going to achieve that was, or get that thesis done, was not at all worked out, and was a pretty convoluted journey. But yeah. So I went straight in. I don't know, I was just driven. By this stage, Paran had been sold to Lifecare, with Dennis Boyd, and he would know well from the franchise model over in WA. And look, they were really supportive to me. By that stage, I had sort of 5 clinics running this sort of functional restoration model through the Lifecare network, and they were very supportive of me doing my PhD. So that was really helpful as well. So yeah, I don't know. I guess I was pretty driven back then.
Yeah. But I mean, having had that functional restoration model built into a private practice arena, you've got one of the hardest things in any PhD is recruitment. So I'm guessing you had a ready, steady stream of participants that you could recruit into a program.
Um, yeah, look, it's a long and complicated story, but I ended up doing this sort of diagnostic accuracy study, or that was one of the studies on. Wow, this is really dredging the memories, but it was actually working with surgeons who were doing fusion surgery, and and they were doing discectomy. Sorry, fusion, and they were doing discography. And so there's this. So discography, was seen at that point, it still is seen as best as we can get as a reference standard or gold standard for diagnosis of discogenic pain. So I did a bit of a diagnostic accuracy study of clinical features compared to discography results, and some other studies around patients who were having surgery. So I actually was dealing with a lot of the surgeons at the Epworth Hospital, which was pretty challenging. But yes, I did recruit some of my patients from from the clinic, and I guess it really got the idea going of having a private practice network as a funder and also recruitment um, opportunity for my clinical research, which is what subsequently has happened.
And what was the title of your thesis, and what was sort of some of the key takeaways in a clinical perspective that people could utilise?
Well, to be honest, the trials that we did were probably underpowered. There were some issues with them. We did develop a preliminary uh, diagnostic model for clinical features of inflammation, but look, really there wasn't a lot from the actual individual studies, because I actually had quite a unique thesis. Half of the thesis was a theoretical piece on the classification of or classification principles and applying them to low back pain. So I delved into the philosophy almost of classification. So I went back to Linnaeus and biological classification, went into medical classification, um, non-Hodgkin's lymphoma, which is very related to this non-specific low back pain thing. So quite a lot of commonality between non-Hodgkin's lymphoma and the classification approach they took. Headache, the classification system for headache. So it was a pretty dense thesis. Half of it was like 60,000 words around the theory of classification. And look, that was probably the biggest, the most important thing that came out of it. I'm sure not many people have read it. But
I'm sure your mum has.
It certainly informed our
thank
future
goodness for mums.
But I will say, my original supervisor pulled out halfway through because he wasn't happy with the way the thesis was going, and I searched the whole of Australia for a replacement supervisor that would, as you say, take into context this biopsychosocial approach to classifying low back pain, and the only person I could find was Peter O'Sullivan, and he was a great supervisor. Obviously, he had an interest in classification at the time. He was exploring around movement classifications and also the biopsychosocial model. So so certainly he was a big part of me finishing my thesis.
Yeah, well, that's great, because it's something you really just need, that someone with having your back for when you're doing a PhD, because it's a long grind, isn't it?
Absolutely.
It certainly is. And once you sort of around 2014, so we're saying 2000 you finished, 2005 you finished your PhD, so
yep.
Then you moved around 2014. Big year. You've been going clinical, you've done academic. Now you almost step into the business world. What was the decision that you came to then, and why?
So I finished my PhD. I set up a research team on low back pain. We recruited 5 PhD students. We started putting together the bones of the STOPS trials, specific treatment of problems of the lumbar spine trials. Funding was an issue. Support was an issue for my research. And so I really wanted a structure that would support my research, at that time, but also long term. And I think by that stage, Life Care had gone through quite a few different corporate incarnations. I was part of the management team there. I had a small equity holding. But just increasingly, there was a discordance or incongruency of the values of the corporate approach and my values and the values of the people that I recruit. I've got a very clear recruitment process with anyone that I put on, that the values are the first and foremost must have commonality. So Michael Strintos, who was one of my young practitioners at the time, and I decided to put an offer into Life Care to buy 4 of the practices. And yeah, look, I really, again, have a bit of an abhorrence of, or did have an abhorrence of business principles. I almost thought it was unethical to try and make money, like an ideological sort of weird sort of ideological hippie sort of thing. But I saw it as a means to support the clinical research and also support our practitioners, who were probably a bit undervalued in the Life Care model and leadership structure at that time. So we got a good price, or we bought it cheaply and went independent. And yeah, all of a sudden I was the managing director of Advanced Healthcare.
4 clinics, and how many staff?
Oh, look, it was pretty small back then. It was probably, I don't know, we probably had about 15 to 20 practitioners and probably or 5 to 7 administrative staff.
Yeah.
Half our administrative staff were virtual, and yeah, we've just grown that. So all of our staff now are virtual. We've probably got about 50 or 60 administrative staff or management, and they're all virtual. So we're ahead of the curve in that respect, pre-COVID. But yeah, so small, but we did have a year or so of really preparing and thinking about our business structures, what our software platforms were going to be, what the ownership model would be, how we would engage business owners in a way that they'd be on the ground and driving things at a practice level. Which, as you know, in private practice, you've got to have that key clinical lead who's really engaged. And then the management structure. So we had about a year of preparing and strategizing all of that. And so we rolled out pretty cleanly and got things moving, and really have gone from strength to strength, with each subsequent year in terms of growth and business systems and clinical systems and clinical outcomes as well.
Yeah. So you don't have an abhorrence for business now and leading other people? I'm sure you're naturally pretty good.
I sort of
at
do,
it,
to be honest. Look, I'd much prefer to be doing my research and my and clinical work, and sort of educational sort of type work. But yeah, it's a necessity. Look, I love our administrative people, and I do enjoy working with them, but it's just a necessity. But look, it's a continued sort of process of trying to systemize things and pass down to sort of middle management, so that can be done independently of me. But I don't know, it's a tricky thing, like business and growth and managing growth and keeping everything ticking along. So I'm still working on that one.
Well, I don't think it changes, does it? I mean, that's the whole thing. Nothing is static in that sense if you take on that responsibility. But so, what does your week look like? I mean, you've got some research. You do clinical. You got business. You're playing the guitar. You got a couple of bands. What does your average week look like then, from a work side of it?
I'm pretty heavily involved in surf lifesaving as well. I'm the head coach down at Point Leo Surf Club, and for 6 months of the year, I'm sort of in the water every day, coaching and training. I dropped the academic role in terms of I just do research now at La Trobe. I don't have any leadership role at La Trobe anymore. So I have tried to pull all that back a little bit, but no, look, I've got a lot of flexibility. I can pretty much do what I want. I don't have to do clinical work. I only work a day a week in the clinic, which is probably a little bit. I'd ideally like to work 2 days, but one day sort of keeps me involved, and it's critical for me to keep seeing patients, to have that connect between the research team and the development of the research concepts. Integrating new research. We've integrated ACT, acceptance commitment therapy, and motivational interviewing are two things that we've, as well as Paul Hodges' more recent work on motor control, Shirley Sarman's work, Peter Sullivan's work, integrating all of that into the clinical model, which then is tested and then is fed into our research programs. I'm the person that does that, and I can't do that unless I'm seeing patients. So that's the minimum. Apart from that, I'm work from home, so we've set us up. We just did a bit of a reno and set ourselves up with a couple of offices for Michelle and me. And yes, I just work from home. Someone else asked me this the other day, actually. Say I could get up and I train. I do some yoga. I get up, I'll do a bit of work. I'll go training, do a bit more work. Sometimes train a second time, train and coach. Going to the clinic on Wednesdays. Try and get away on holidays as much as I can, which has been a struggle after the COVID thing. I think we're still stuck a bit in this. We are in this sort of COVID, not you WA people who sort of managed to get away with it. But yeah, the travel routine hasn't quite got back to what it should be. But yeah, that's a big part of what I try and do as well.
Yeah. And then once you've done all this, then the next pinnacle to climb for most physios, if they want to keep climbing mountains, is specialisation. You went ahead in 2018 and completed yours in pain. I mean, I can see a reason for it, but just out of interest, why pain, say, and not musk?
Yeah, look, it was sort of when the musk program first came out, the fast track musk program. I can't 10 or 12 years ago, I did actually sign up for that. But it was just not the right time. And look, to be honest, I didn't really think specialisation was a real thing. I wasn't fully convinced. But over time, clearly, it is a thing that's important for our profession. And, there's benefits to the people who do it as well as the patients. And so just through my work in multidisciplinary pain, historically, I haven't really been sort of fully connected with the pain community because we've come from this sort of different, not this, the most of the pain community comes from the hospital sector where they've got multi-D programs. So we were running we started multidisciplinary in about 2010, and so we've been doing them in private practice since then. And Anne Daly just actually told me about the titling process and said that the deadline was shutting. I said, oh, I probably should apply for that. And then she told me about specialisation, which was shutting about a month after that. But, that sounds like a good idea. I had already started my original contribution for the college. So I was about a third of the way through that. And so I thought, I'll sign up. And look, I did it because, again, it was probably, to be honest, a bit of something that I just had to do if I was the leader of this multidisciplinary group. But similar with my masters, the further I got through it, the more I realised what a contribution this was making to me as a clinician and as a person. So it was very challenging, but it was definitely, hugely beneficial.
Yeah, I think that's so true. Like, you sometimes sign up on a whim, but you don't realise the beneficial outcomes of taking that challenge. And I mean, it pushes you. It's hard, but that's what a lot of those things do, isn't it? Like, you have a goal and you don't realise how good it's going to be for you until you really get stuck into it and commit that time to it.
That's it.
As an aside, I didn't know it, but you speak fluent German, which, living in Australia of all languages, it's not Indo, it's not Italian or French. Like, how did you come to do German?
Actually, my father's Indonesian, or was Indonesian, but so everyone says, "Oh, do you speak Indonesian?" I go, "No." Apart from a couple of things picked up on surfing trips, but no, my wife's parents were German, and they've got a great family, and who welcomed me into their home. And on our honeymoon, after we got married in 1993, and went overseas and ended up getting a job in the ski resort in southern Germany, next to near Michelle's relatives. So
as you do,
I had that immersion sort of thing of language. I was always told I was crap at languages at school. But yeah, I picked it up pretty quickly. I was working as a physio, and I learned sort of the words for arm and pain and move and lift and all of that sort of thing. And picked it up pretty quickly. And actually, after working there, came back and spoke German to our kids until they were 18, just exclusively German, just to sort of help them with the language as well. So that immersion sort of thing definitely seems to be certainly my experience, that's the way to learn.
Yeah, and Michelle speaks German obviously as well.
Yeah.
I think that the
so helpful in a party when you want to sort of just talk about someone who's standing over there, unless they speak German as well, which can be.
And you don't know that till the beer comes flying towards you.
That's it.
Oh yeah, so jumping to a few little questions. We'll hit all the heavy ones are gone now. What would you say is the hardest lesson you've learned as a physiotherapist?
These questions, I do have some answers. The hardest lesson, I can't find it, so I'll just wing it. The hardest lesson I've learned. Well, I think the two things that stick out for me is things that, the hedonism of youth. You think you've got the answer, and you push ahead with that, and probably, push it at times too hard, and maybe you're a bit forceful with the way you try and communicate that. But yeah, the more research I've done and the more experience that I've got clinically, things are complicated. Back pain's complicated. The biopsychosocial model's complicated. And the more research that's done, that people are complicated. There's definitely a humility that I've had to learn. And the specialisation process was a big part of that. because as you know, you do get challenged no matter who you are or how experienced you are or whatever your skills are. You get challenged at a very deep level, and you either fail or you come out of that a much humbler and person with a much greater perspective of your sort of place in the whole sort of ecosystem of health. Yeah, things are complex, and you've definitely got some capabilities and knowledge, but it's got to be contextualized with what you don't know.
Yeah, things are not as simple as they seem.
That's it.
What, for $200 or less, what would you say has been the best book, tool, or app that you've used in your development as a physio?
Well, look, the short answer is get a journal subscription. I'm really, my whole life, hopefully I've communicated that, has been about self-directed learning and active learning, driven by my sort of passion. And I just found reading papers, reading them in full, digesting them, getting another paper, cross-referencing, comparing it, and just developing your research literacy over time through those readings, and then starting to see the clinical sort of pearls come out of that, and interface that with your clinical practice. Say journal subscription to musculoskeletal science and practice, or some sort of clinically oriented physio-based journal like that would be good. But actually, I went to find my original copy of Vertebral Manipulation, the third edition from Jeff Maitland, and I'd given it to someone, and it was heavily annotated. Like I read it from cover to cover. It's like reading Tolstoy. So I went and I've lost it. So I found another one online. So you could do worse than buying that and reading those original descriptions from Jeff, because he was clearly a very gifted and multimodal physio. He wasn't about doing central PAs and reassessing flexion and straight leg raise or something. He was very much a visionary.
And as something of interest on that too, because a lot of our younger listeners probably find the concept of reading difficult, but they like watching. So there's a really good interview with Jeff on our YouTube channel, which was gifted to us for people to look at, and that in itself is an amazing conversation, because it's just not something you get now. And as you say, he's a lot more than what comes across in the books in regards to his clinical prowess and understanding of human nature too, which is pretty good.
100%.
What would you say is your most out on a limb decision that you've made, and what was the outcome of that decision?
Well, it'd have to be the split from Life Care. I was on a salary, pretty good salary. No one was pushing me out. I was doing well commercially, clinically, had a good reputation. But the outcome of splitting is that we've grown. I don't know how many fold, fivefold. Sorry, and we've got an amazing team of about 60 practitioners now. But even more exciting is that vision of having a research infrastructure. So we've got research assistants, PhD physios who've come and work for us and divide their role between clinical and research administration. We're running RCTs on motivational interviewing with Nick Taylor and Paul O'Halloran from La Trobe, running another RCT on motor control with Paul Hodges. We've got some RCTs running on STOPS implementation overseas, and all of this is funded through the business, and as you say, the recruitment side of things through the businesses has really come to fruition. So that would have never happened in the corporate environment. I sort of hoped, I sort of had this vague sort of, I had a vision, but I never really fully believed that it would work out this well. So that's definitely, and it was purely profit, just for the business people out there. This was Michael Strintzos's gift to me. He said, we get paid by profit. That's how you make your money. So we made a very efficient, lean business, and it's been successful. So.
Yeah, and are you saying some of the profits from that business are flowed into the ability to hire, recruit, and train, but also essentially fund research through those profits?
Yeah. And there's a commercial value to that. I mean, most decent sized business have some sort of research R&D sort of type arm, but they'll fund research. I mean, there is a fairly obvious link between investment in research and connection to research and collaboration with researchers and a commercial benefit. But with us, it's very immediate because we're the ones that are doing the research, and it's very clinically relevant research. So it means we're attracting the right sort of people who are committed to just helping patients, and the research is part of that, helping patients.
Yeah. No, I mean, was there a model out there that you could lean on and look towards, or was it really just saying, want to try and combine the research with the clinical and fund it through the same process?
Look, I don't think, well, there wasn't a model when I put it together. I think Peter O'Sullivan's had it, I'm not sure whether he still does, but he had a number of clinics over in WA, and that was sort of a similar model. He had an academic role and the private practice role, and a number of clinics that supported the research. So I think it's similar to that, but that was not, we just sort of developed it independently.
Yeah, out of necessity. What are 3 things in your professional life that stand out for you so far?
I just think, well, the potential of physio, I keep coming back to this, the potential of what physio could be when it's really developed well. So I'd like to think I've discovered that in my own clinical practice, and I'd like to think that our practitioners that I'm mentoring are developing and helping the patients fulfill their potential in that way. So yeah, that potential of physio, but equal to that and a counterpoint to that is how that potential is not really being supported, in my view. I mean, I ran the physio department at La Trobe for 3 years. And it's a very challenging environment. The undergraduate or whatever the postgraduate programs for your standard physio degree, they're so squeezed from all of these different competing influences in the curriculum. And I don't think the undergraduate programs are sufficiently meeting or realising that potential of physio, if you like, and it's multifactorial as to why that's the case. And then what do you do once you graduate? And most 70% are going into private practice, and obviously there's a lot of burnout, which I know is a big topic for this podcast. So yeah, there's problems. There's this amazing potential, but the realisation that potential is an issue as well. And the third thing would be just the flexibility. I mean, my daughter's a doctor and is going down the psychiatry program. So she's got this amazing structured sort of thing just laid out for her on a platter, which at some level is really appealing. Certainly for me, it would have been really good at some stages, but just the ability to, again, hopefully I've painted that picture, just to sort of put yourself in the space and be glass half full and try and recognise opportunities and to go with them, and to sort of hack out this sort of individualised, approach to your career. It's an amazing profession to do that. There's so much flexibility in it. So much opportunity, which is probably the third one.
Yeah. Going back to the advanced health care, is it solely low back pain, or you actually are treating everything off the street? It's just that there's a strong low back pain focus because of the research side.
Yeah. So look, we started off as a low back pain, predominantly low back pain, but over time it's just spread to all sorts of chronic pain. We see a lot of chronic shoulder problems, sort of neck, shoulder, sort of combined influences, neural impacts as well. A lot of post-shoulder surgery, chronic pain, quite a lot of chronic knee pain, again, multiple surgeries. So yeah, it's just chronic pain in general, just sort of widespread. Some might call it fibromyalgia, nociplastic dominant, whatever you want to call it, but that sort of widespread without a single cause, biological sort of cause, with that heightened sensitivity. So yeah, it has diverged from the original model of low back pain, and that's why one of our trials, the MI trial, the motivational interviewing trial, is around. We're particularly interested in self-efficacy in chronic pain, which is obviously a big predictor of future outcomes. And it's one thing, particularly in the compensation area, the compensation systems take away your self-efficacy basically. And so that's one of the areas where we perform not great at. And so we're hoping that the MI trial will help us to empower patients more effectively with chronic pain as opposed to just back pain.
Yeah, I noticed on your website that, you got your standard group of physios, but there's a huge bunch of doctors with a special interest in pain and anesthesiology, and then another huge cohort of psychologists and psychiatrists. So, it's a nice diverse team, but I'm guessing, and that's not a good thing to do, but as a physio managing those groups of people, it's a bit of an unusual structure, isn't it, in far as the medical model goes, so to speak. How do you find that process of, managing doctors and anaesthetists and psychologists that's sort of outside of our normal chain of command, so to speak?
Yeah, good question. We only recruit people that are really genuinely focused on, these values again. So collaboration, collegial, not hierarchical. So, some doctors, can have that sort of hierarchical top-down approach, and that's definitely not the way it works with us. So getting the right people in is the first key point. And we've got clinical directors. We've got a medical clinical director, Aston Wan, a psychology clinical director, Charles Ruddock, and Adam Turnbull's the physio clinical director. So the four of us work together collaboratively to provide that feedback. We are a pretty feedback-oriented team, so we collect data and we feed that back to practitioners in various ways to help, monitor and improve clinical performance. And look, we've generally found that practitioners, they can be a bit reluctant to that, resistant to that initially, but it's a cultural change, and once they buy into it, I think everyone agrees that it's a better model for our patients.
Yeah. No, it's great. I mean, hats off. It's fantastic. It's the whole way it's supposed to be, but sometimes it can be quite difficult with egos that are built up through a structured, institutionalized system. And I guess that's what I'm saying, is that you recruit more on values rather than other things that maybe other people recruit for. John, if you could step back to your younger self, what would be 3 pieces of advice that you would share, knowing what you now know?
Yeah, so look, I think that theme that I touched on earlier around things being more complex than they seem, and perhaps using that to temper some of the hubris and arrogance of youth in your 20s and 30s would have been helpful. It's hard to temper that in a lot of people and myself, but definitely that one. I think, I think, as I said, again, similar to what I said earlier, that notion of your passion. I think I was just sort of instinctively, I think I was more following my nose. I wasn't consciously following my passion. I wasn't really consciously identifying my passion or thinking of it in that way. But ultimately that's what the behaviour was. I think I found it, sort of just happened to find it. But it's probably more around, as I said, sort of identifying those opportunities and taking them, and you sort of almost develop your passion just by doing that, by being open to those opportunities. But probably the thing that I haven't said is just that confidence, that sort of self-efficacy thing. I had a lot of doubts about my capabilities. To be honest, I had imposter syndrome right up until specialisation. I think specialisation cured me of it. Maybe until the next sort of hurdle first comes along. But just backing myself, everyone's got their own strengths and weaknesses, and everyone's got their own individual mix of those, and just realising that, you've got lots of strengths and you've got lots of areas to improve on, and just back yourself to do the best that you can and get the outcomes, which is something that I probably only really developed actually since we separated and we set up Advanced Healthcare. I was forced to back myself then because I was running the show, and I probably would have done better if I was backing myself a bit more strongly earlier on in my career.
Yeah, well, good points, and it's much easier to say those things from hindsight, isn't it? To look back and say, well, I could have done that 5 years earlier, but the reality is I don't think you can. Like, you do it when you can do it, and there are different factors that contribute to your capacity to do it. But I do like the analogy of, take a bigger bite and learn to chew a bit harder, because sometimes we do sit back in that comfort zone. And, definitely talking to a lot of other people that come on Physio+10, there's been a theme where they've sort of said, look, you've just got to step out. You've got to take the opportunity. There's never a right moment. You've just got to back yourself and be willing to pedal or chew a bit harder, because that's how we grow. And I guess that's the essence of it. We don't grow if we sit and still. And, it doesn't matter which direction you grow in, but having that willingness to take on a challenge and develop skills from it and be a bit uncomfortable. I think that's the other thing. But, it's okay to be uncomfortable. It doesn't always have to be comfortable. So I
think related to that, and this is actually where it all came from, where I learnt these skills, is through sport. So as I touched on earlier on, I was a pretty high level kayak paddler, and I learnt discipline and I learned how to apply myself basically and set goals and to then see the benefits of having of that, applying that discipline and having those goals. And I think that was really formative in my personality, which sort of led to these behaviours later on, which is, sports is not for everybody, but that's why I'm the head coach down at Point Leo, is because I do that to help young people develop those attributes through sport. And I think it's a really nice contained environment if you've got a supportive coach and supportive parents who aren't, going over the top to just, as you say, get outside your comfort zone a little bit and feel comfortable there.
And realise that it's okay to be outside the comfort zone. I think that's another realisation that somebody, light bulb moment or penny drops. It's because it's uncomfortable doesn't make it wrong. And in fact, often that's how you learn something else, either about yourself or the environment or what your potential is. And I'm definitely agree with those things, like that sentiment of being uncomfortable. It's good. It's okay.
Yep.
It helps
100%.
you. Looking forward, and this is sort of a little bit crystal balling, where do you see, or where would you like to see? You've mentioned and touched on it a few times, but where would you ideally see our physio profession being in 5 years' time or thereabouts?
I've just come off. Oh, is a wish list. Like, I've just come out of the World Low Back Pain Congress. It was a very interesting meeting, where I did a keynote there around guidelines and implementation studies around guidelines, particularly with regards to low back pain and some of the problems with the evidence around guidelines, and some major problems with the evidence around some of these implementation approaches. So if you're interested in that, you can have a look at my LinkedIn profile. I've got a video of that presentation. It's a challenge. I mean, I've articulated what I think the potential, doing a really thorough psychosocially informed, evidence-informed assessment, taking those features, using clinical reasoning to identify the barriers to recovery. This is all part of the specialisation process, and then applying individualised treatment to those barriers in a prioritised sort of way, and very patient-centred way as well, using your communication skills and engaging the patient. But that potential and how to actually get, more practitioners reaching that, apart from doing the specialisation program, which is obviously fairly niche still, is a real challenge. And I think in parallel with that, we've got these sort of Trumpian sort of type themes coming through with Twitter or X, and pretty prominent people pushing some strong opinions around that may not necessarily be, fully balanced. This pendulum that I was talking around about pushing too far and the psychosocial away from the biological, which has been talked about a reasonable amount, the pendulum needs to come back a little bit. I don't know, there's so many challenges, and we're trying to contribute to that in a positive way, and other researchers and academics trying to meet those challenges. But it's tricky. It's tricky in back pain in particular, because there's such a lot of research that goes on there. So I'm hopeful for 5 years. I think 10 years I'd be more hopeful. And I hope that I can make some contribution to that in some small way.
So segueing to that, where do you see yourself focusing on, and what are your sort of goals for the next 5 years for you?
Well, we've got to finish these trials. So we'll finish the implementation studies overseas. MI trial, the motor control trial. We're hoping to start a trial on ACT, on acceptance commitment therapy. So finishing those trials, it'll be fascinating to see what happens with the STOPS trials in different contexts, in India and other countries. So maybe I'll be bearing it. Like we're not about pushing something that doesn't work in a range of different contexts, but hopefully it'll show some positive results, and that'll give impetus to push that out more broadly through more implementation studies. I'm hoping I won't be managing our administrative team so hands-on, Doug, and I can just become this wise elder, sort of continuing to guide the research team and still treating patients and helping support our practitioners. I can't really see myself retiring, but a lot of travel, work 2 or 3 days a week, flexible, that sort of thing.
Sounds good. Hey, John, I've loved learning a lot more about your history and what has been important to you, and also the way you've crafted your career over this sort of last 30 years. So appreciate very much you sharing that with us on Physio+10, and wish you all the best coming up to Christmas, but also going forward in your physio endeavours in the next 5 years.
Thanks, Doug. Appreciate the opportunity, and all the best to you as well.
Thank you. Thanks so much for listening to this episode of Physio+10, in which I trust you gained some valuable insights. It'd be awesome if you could leave your 2 cents worth as a review or rating of this podcast, and I look forward to sharing the story of another trailblazing physiotherapist with you in 2 weeks' time. Stay safe. Bye for now.